My name is Nick Holbert Williams. I'm a Professor of Behavioural Medicine at the University of Chester. We know from various pieces of work that how people respond to cancer, the psychosocial impact of cancer essentially, can differ based on people's personal status. So we know, for example, there's age discrepancies, there's ethnicity discrepancies, males and females respond differently to cancer. My group at the Chester Research Unit for the Psychology of Health have been doing some work looking at the impact of other demographic differences that aren't studied so much in the literature. So we've been exploring in particular the cancer experiences in people who have an intellectual disability, so have lower intellectual functioning. And in a second study we've been looking at the impact of sexual orientation on cancer experiences. So in that project we've been doing a secondary analysis of the National Cancer Patient Experience Survey, comparing responses from heterosexual, gay and lesbian and bisexual people. So the first study was, first program of work within that was looking at the impact of intellectual disabilities. And what we did there was a series of 3 different studies. So in the first one, we did some qualitative work. We recruited 6 patients from North Wales and the North West of England who have an intellectual disability and who had been diagnosed and treated for cancer. So we interviewed those 6 participants about their experiences of cancer diagnosis, cancer treatment and cancer survivorship. We also asked them to identify other people who played an important role in their cancer care. So for some people that was family members, for others it was their intellectual disabilities care staff, for some it was their oncologists. And the kind of themes that came out for us in that study there was a few important findings. I think one was that there was a big barrier to communication, that the healthcare professionals in the oncology setting don't really know how to communicate very well with somebody with an intellectual disability. They've not been trained for it, and it's not very common, so they don't have kind of experience of how to deal with that. So that was a bit of a barrier. And as a result of that, the person with an intellectual disability wasn't very informed and was often quite confused about their cancer diagnosis. The care staff also rely on family caregivers and the intellectual disabilities carers quite a lot to be a kind of liaison to try and communicate as best that they can. But it's often that group of people who are trying to protect the patient from psychological distress, psychological suffering, so they tend not to tell them too much. They try and evade difficult questions. So ultimately you get somebody who could be empowered to play a bigger role in their cancer care, but who's being protected. So we then followed that qualitative study up with some work with oncology nurses about what the barriers to communication are and how we might overcome them. So we did a survey with UK oncology nurses using an experimental design. So we described to them 4 fictional patient cases. 2 of them had clues in there about that patient would have an intellectual disability and 2 didn't. And we asked them 12 questions about how they would communicate and treat that patient. And then we compared between the 2 types of vignette. And we found significant differences, that the patient with a disability, the perception is that communication would be more difficult, care would be more stressful. It was overall a more negative picture. So we're now doing a 3rd study in that program of work where we've developed an online training package for healthcare professionals to try and overcome some of those barriers, to try and teach them how better to communicate. That study is still ongoing, so we don't have any findings yet. In exploring another demographic minority group, we've been interested in the cancer care experiences in people who are from a sexual minority group. So in this piece of work, we've done a big secondary data analysis. So each year the NHS commissions the UK Cancer Patient Experience Survey, which is sent out to all patients who receive a cancer diagnosis and are treated in an NHS hospital. So we were able to access the data from the 2013 survey, which actually summarises responses from people who were treated towards the latter end of 2012. And almost 70,000 people responded to the survey that year, so it was a really huge data set. And what we were able to do was to access that data set and separate out participants according to their self-reported sexual orientation. So we compared all of the questions about cancer experiences and cancer care between heterosexual people, people who identify as lesbian or gay, and people who identify as bisexual. And we controlled for the confounding variables such as gender, age, mental health status, those kind of things. And what we found was essentially significant differences between those groups on 16 out of the 70 questions. In all cases, they represented a much more negative cancer-related experience for LGBT people, especially so for bisexual people. We're not quite sure why they were a kind of outlier group, and there's probably some work to be done there. But across the board, they relate to, I guess, three overarching themes. The one theme is that LGBT people didn't really feel that their care was very patient-centred. They didn't feel as involved in their treatment decision-making as they wanted to be. So their relationships with healthcare professionals and their involvement wasn't quite what they wanted and what they expected. The second theme is that the information that was provided to these groups, both in communication and in terms of written resources about treatment, symptoms, aftercare, those kind of things, was perceived to be worse by LGBT people. And the third one was a really clear theme of social isolation. So LGBT people felt that they weren't having the kind of supportive relationships that they wanted with care staff, and that was compounded by the fact that they don't have informal support. So there were two questions that relate to the involvement of friends and family, and whether it's their own choice not to involve those people or that they don't have them there. Their responses were simply that they don't have access to that support. So they really are socially isolated in that whole context of not really being as involved in their cancer care as they want to be. A lot of my research over the past 15 years has been looking at psychological outcomes in distressing cancer patients. And we know from various pieces of work that up to 75% of patients will suffer from psychological distress, and around about a third will reach clinically significant levels of anxiety and depression at some point during their cancer treatment or survivorship. So we're really interested in what we can do to help prevent that, and when it does occur, what we can do to try and treat that and manage it in a way that's acceptable to patients and that's effective. So there has been previous literature on this, testing out different interventions, and actually what we find from the intervention research to date is that cognitive behaviour therapy is the most effective type of intervention, but the effects seem to be quite short term. It's also quite an intensive intervention, so patients have to commit a lot of time, a lot of energy into that kind of intervention, which leads to poor uptake and poor adherence. So across a programme of work over the past 5 years, we've been looking at a different type of intervention framework that we think could be useful here, and that's called acceptance and commitment therapy, or ACT for short. So we've done various pieces of work at the University of Chester. We've looked at some pilot data using surveys to see how ACT constructs may be predictive of patient-reported outcomes, and we've done some acceptability work. So what I'm going to be doing tomorrow is a workshop for delegates at the conference here on kind of an introduction to ACT and how it's applicable to cancer care. I think there are two things. I think my recent work, which has been looking at the demographic minority groups, that's really flagged up for me the importance of good communication between healthcare professionals and patients. We've done an awful lot of work over the past 20-30 years at improving the quality of communication we have with patients, and I think we've come on leaps and bounds, but I still think there's a long way to go. I think one of the possible effects of the way we've been doing communication skills training is that we have a very effective but standardised model, and I think the work that we've been doing shows that actually we need to build on that and tailor that communication to different people's needs, and I'm not quite sure we're getting that quite right. So with the equality agenda, what we're talking about is not necessarily equality of what we provide, but equality of opportunities. So for LGB or people with an intellectual disability to get the same kind of care and the same kind of outcomes, we might actually need to provide really different kinds of information and different kinds of communication. So I think communication is something we need to do a lot more work on. I'd say the second thing that I think is really important is, and this is from my perspective as a psychologist coming into a nursing conference, is that we can't overlook distress. We have a lot of research out there that shows that distress is prevalent, and we know that distress impacts quality of life. It impacts on how patients adhere to treatment advice, and essentially we know that patients who are distressed are more complex to manage. They become more expensive to manage through the course of their illness. So it doesn't go away, so we need to do something about it. And I don't think the interventions that we currently have evidence for are the best that they can be. And I think we need to look at developing new models of psychological adjustment and new interventions to try and reduce the distressing impact of cancer. I think it's a great conference. I don't very often come to nursing conferences. As a psychologist, I tend to stick to my psychology world. But it's really great to come here and talk to people who are delivering care. Because actually I think one of the important things for psychology to do is actually to get our message out there and to translate our tools for other professionals to use. So actually being able to come here and talk to nurses who are at the kind of forefront of patient care is a really great thing to do. I think the programme for the conference is great, and especially the keynote this morning on social determinants of health, I think was absolutely fantastic.